Hey, Sumaya, welcome. Thanks so much for doing this.
Hi, Dan. How are you?
Well, it's just a few of us on at the moment, so let's just give people a chance to join, Sumaya. Thanks.
No problem.
And you obviously know Nasira.
Yes.
Right. Okay, everyone. So for those that don't know me, I'm Dan Stein. I'm head of the Department of Psychiatry at the University of Cape Town, and this is our first lecture of the year. So welcome back. And actually, with that in mind, I'm going to suggest that we all switch on our cameras, so that we can just for a moment just see each other and know that we're real live people. Now to see everyone for the first time, many of you. Hey. You could perhaps just stop sharing for a moment.
Yeah.
Thanks. Okay, great. So for those just joining, we're having a brief greet. Many of us haven't seen each other for a while. I'd also wondered actually while we joining, and that perhaps perhaps enough people have joined that we won't be interrupted. Just to think, I know that actually it's been an incredibly difficult time for a lot of people over the last several weeks. That probably also accounts for why we don't have the whole department here at the moment. But I'm just thinking maybe it would be appropriate just to take a moment to acknowledge those people in the department who've been unwell or lost loved ones. Just for those people that haven't had those losses, think about what they have and where they want to go in the year. So I think if that's okay with everyone, let's just maybe take a moment. Okay, thanks very much for that. So really nice to see those people that have switched on their cameras, and welcome also to people that are not from the department. I see a few. Thanks for your note, John. And it's a pleasure to welcome everyone back, and also to say that this is our first social responsibility meeting for the year, organized by the Social Responsibility Committee, this year headed by Nasira. And so I'm going to hand over the mic to her. Please, Nasira, welcome, and thank you so much for doing this.
Okay. Hi everybody. So for those who don't know me, I am Nasira. I'm the clinical psychologist at Lentegeur Hospital, and has taken over as chair of the Social Responsiveness Committee. So yeah, it's wonderful to be able to host at our first meeting. It's wonderful to host Sumaya. So Dr. Sumaya Mall, as she's now known, grew up in front of me. So we come from a tiny little town of Simonstown, and her parents still have recently moved back. So we are so proud of her and so proud of her achievements. I just felt it so fitting that I get to introduce her. So Sumaya is the senior lecturer in the Division of Epidemiology and Biostatistics, and she's at Wits University, School of Public Health. She started in August 2016 after being in Columbia University doing a postdoctoral degree there. And she was also a child of our department. So she was mentored by Professor Ezra Schasser, Crick Lunt, and Dan Stein. Sumaya teaches on the Wits Masters of Science in Epidemiology and Masters in Public Health, and the forming Bachelors of Health Sciences Honors in Public Health degrees. She also supervises postgraduate Masters and PhD level dissertations, in addition to a considerably long teaching load. She is a productive researcher and has over 50 peer-reviewed publications, and is a Y2 rating from the South African National Research Foundation, and is a collaborator on local and international grants. Sumaya talk is entitled Analysis of Traumatic Events in Rural South Africa, Intersections of Epidemiology and Community-Based Research. The talk will focus on data examining traumatic events in older adults from the MRC, Wits, and Cohort Rural Public Health and Health Transitions Unit. And again, Cohort is an integral part of the Wits Public Health School. And the talk will also illustrate its long history of community engagement and social responsibility. So over to you, Sumaya. Thank you so much.
Thanks, Nasia. I'm just gonna try to share my screen again. Can everybody see that?
Yep.
Okay. Okay, thanks. Thank you very much, Nasira, for the invitation and the introduction, which was also met with a lot of enthusiasm from Petrus, and Sandra's administrative skills don't seem to change. So thank you very much for helping to set this up. So as Nasira mentioned, based in the Division of Epidemiology and Biostatistics at Wits, we're in the School of Public Health, where I've been based for nearly 5 years now, 4.5 years. And the talk is going to focus on analysis of traumatic events in rural South Africa, and I've called it Intersections of Epidemiology and Community-Based Research. So let's see how I integrate specific themes. So what I really want to focus on is, it's an overview of sort of social responsibility and community engagement, which seem to be terms that are used interchangeably in relation to research. And there's also the term public engagement, which also seems to be a synonym. So I'm going to cover some of those, also from a research perspective. And I want to describe these intersections of social responsibility or community engagement or public engagement and epidemiology, since I'm based in an epidemiology unit. Now, Cohort is part of our Wits School of Public Health. It's a health and socio-demographic surveillance system known as an HSDSS. And there's a lot of research and community engagement activities. In fact, I think Cohort is very much a model for research and community engagement. So I'm going to talk to that. I'm going to present some Cohort epidemiological analyses of traumatic events. So this is work that I'm leading in Cohort among older adults. And the study that I'm going to refer to is called the Health and Aging in Africa, or the HALSI study. And we're going to try to illustrate some synergies for community engagements in the area of traumatic events. And then also perhaps to kind of chart the way forward to try to foster mental health research, epidemiology, and community engagement in Cohort, and perhaps propose an argument for measuring resilience as part of community engagement. So just to say, this is the Wits School of Public Health, where I've been since 2016. It's a difficult job at times, but also I've been very, very happy here for the last 4.5 years. So we're situated in Parktown. We're just opposite the main Wits Medical School campus. It's quite a new building. That's where I'm sitting right now. And you might just hear a Joburg thunderstorm, which obviously is out of our control. So what's interesting is that I'm actually co-chairing a research committee within our School of Public Health with a colleague of mine, Professor Jane Googe. It's supposed to be modeled on the faculty research committee. So I've been digging out these research strategic objectives that the Wits School of Public Health has. Now, among sort of increasing peer-reviewed publications and staff with NRF ratings and independent funding, I was also pleased to unearth a strategic objective, which was about increasing and enhancing the relevance of our school's work to communities with the purpose of driving sustainability of the school. So there's sort of short-term and long-term goals, although, in busy teaching environments and service environments, we usually tend to be long-term rather than short-term. But these goals, to pursue research and messages or materials that are relevant to communities, to create space to engage with non-academics, to bring the community voice into research, and to be visible and do relevant work in the community to an extent that the community supports the university. So it's quite interesting that there is a kind of theoretical goal about engagement and community engagement within public health research. So over the last decade, I think, there's been an emergence of community engagement research. And as I said before, the synonym is public engagement. It seems they're used interchangeably. And when I did a search on PubMed, I used just the term community engagement and research. I got over 48,000 hits. But adding the term mental health only brought up 6,847 hits. And then adding the term epidemiology was only 1,517 hits. Now, obviously, not all of these papers that come up with a PubMed search like that are going to be relevant. But let's just have a closer look at some of the stuff that I found. So there was this rapid review by a group at Lancaster in the UK, led by Pamela Attrie, who talks about the experience of community engagement for individuals and published a rapid review of the evidence. So if you look at this table, a number of the papers that were integrated into this rapid review were around sort of community support, drawn in areas of social and economic deprivation, interest groups, so kind of really engaging with users and some sort of stakeholders. There's a lot of emphasis on disadvantage, okay? Sort of vulnerable groups, older people, unemployed people, those with the limiting long-term illness or disability or mental health difficulties, time bank participants. So there's a whole range, but there is a kind of an emphasis on deprivation and on vulnerability and sort of integrating people like this into research. So really the review referred to community engagement as a range of approaches to involve communities as a way of reducing health inequalities, of addressing social determinants of health, but also acknowledging that sometimes there are pitfalls to including community members in research, including a risk to well-being. And in terms of kind of the sort of social responsibility or community engagement in public health or mental health research, again, it seems that there is some work from the global north, and this is not a very recent paper published in the American Journal of Geriatric Psychiatry, but it looks at developing a community academic partnership to improve recognition and treatment of depression in underdeserved African American and white elders. So again, an emphasis on vulnerability, an emphasis on racial inequalities, on older people. And again, this paper also gives quite a useful definition to community-based participatory research, a prevalent research approach to encourage public involvement and engage diverse communities to address research concerns that require working with different populations on ecologically based issues. These issues include social, cultural, political, and economic systems that influence behaviors and impact the access to resources. And the community engagement aspect makes it a particularly relevant approach to reach the underserved, reduce mental health disparities, and work with populations who historically mistrust research and healthcare institutions. So this idea of mistrust of participants is something that I'm hoping to bring through in the talk. So there are several essential elements, this article says, of community-based participatory research to enable community partnership and citizen involvement to support the inclusion of organization leaders and citizens in the decisions and discussion. And the CBPR approach was used in this instance to develop shared approaches to resolve problems, reach people who need care, and raise awareness of health issues at the community level. And this approach generated an opportunity to promote synergy between the community and community groups by using each member's unique perspective and distinct set of skills and experiences. It's a collaborative approach that helped participants create projects. So it's really about collaboration, about inclusion, about bringing community members into sort of the hypothesis generation and finding out what's important and what could be research priorities. Then, as I'm still on PubMed, and adding trauma to a search on public engagement yielded about 1,145 articles, adding resilience, a means of adapting to stress and adversity, which is work that I'm trying to analyze within Adjunct Court, yielded about 974 articles. So it doesn't seem that like mental health or trauma have really been priorities in terms of community engagement. So there's definitely room to do more. And I mean, this is one of the papers that came up with my search on trauma. It also was around prioritizing childhood adversity, and it also involved a lot of interviews with stakeholders, trying to just see what could be the priorities in terms of childhood stress or childhood adversity. So there's a lot around formative work before an epidemiological study. And this is just a similar sort of paper on resilience, which found that resilience interventions that support, this is in relation to adolescence, is really around building positive relationships with parents and peers. So in conditions of adversity, like we see a lot in South Africa, there might be people who actually are free of, various, they'd experience the stresses, but they don't seem to be at risk of the outcomes. And there are various ways of measuring resilience, which I'm also going to talk to. Okay, so if I could move on to Agincourt. So our Wits School of Public Health has teaching and research entities. That's how it's structured. So we have 3 teaching divisions: the Division of Epidemiology and Biostatistics, where I'm based. So we coordinate the MSc in Epidemiology and Biostatistics, and we have a lot of students. I think the demands are increasing to study epidemiology in the face of COVID-19. So we're getting over 1,000 applicants every year. And I think that the faculty would likely want to admit all 1,000 but they agree sometimes to admit about 50. There's also a Health and Society division, which coordinates the MPH. So a slightly less quantitative stream, but certainly with some quantitative training and a lot of professionals who take on the MPH, and many of them who work in health systems, and a Department of Community Health that train public health medicine registrars. In addition, we have a number of research entities. We have a Center for Health Economics, now also involved in teaching health economics to the MPH. We have a Center for Health Policy, which has a very, very strong history. And we have our Agincourt unit, where I'm going to present some data. So the MRC and Wits Rural Public Health and Health Transitions unit is Agincourt. So even though I'm not employed by Agincourt, I base my research out of the rural site, which I'm going to describe in a bit more detail. So this is just a map. So you can see where the study site is. It's in Mpumalanga, so it's not close to Johannesburg. It's probably about a 5 or 6 hour drive. There are a few flights that go out that you could fly to Nelspruit and take a 2-hour drive to the site in rural Bushbuck Ridge in Mpumalanga, where there's also a Wits Rural campus. So it's not only health disciplines who work out of the Wits Rural campus, there are also botanists and ecologists, a range of disciplines. It's close to the Kruger Park. It's a very, very nice area to visit. The catering and accommodation has improved substantially since I've come to Wits. It's now pretty 5-star, probably not during the pandemic or lockdown. We haven't had many trips out there, but it's really, really quite something to see. So Agincourt, this Wits Rural unit, is a health and demographic surveillance system, okay? So there's longitudinal research where epidemiological data on risks and exposures and outcomes for a number of illnesses are collected as part of a census, and it's part of a network known as the In-Depth Network. So the actual Agincourt site consists of 31 rural villages with quite sparse water and healthcare access. Okay, so it's a poor area. There's high HIV prevalence. So for a psychiatry audience, I think you would find it very interesting that during and following the civil war in Mozambique, there was an influx of refugees into the region since the 1980s. So in terms of an environment to study trauma, this is actually quite a fertile area. And it's had this HDSS system since 1992. So in a way, a response to the demise of the apartheid era and a real way to tackle and study inequalities. So you can imagine since 1992, there are a wealth of longitudinal data. And as I've said, it's located in Bushbuck Ridge in Mpumalanga, and there's a robust research infrastructure which supports advanced community-based research. And I'm going to highlight a range of studies because the HDSS is actually a very fertile ground to recruit samples for cohort studies. So cohort studies where there's a follow-up component where you can follow participants through time and monitor them. So this is just a diagram of some of the studies. In Agincourt, there's a lot of work on migration and health. There's a lot of interest in adolescent health. One of our main collaborators for work on adolescence is actually Professor Alan Stein, the head of psychiatry at Oxford. He works with us on some of the adolescent studies. We've got studies on adults, health and well-being, and kind of trends and transitions, which is really typical of any study where there's follow-up. And it's a clinical and patient-oriented platform. There is a rural hospital, a Tinswalo hospital, which is also close by, and there are referrals there. So just to sort of talk about the intersections with epidemiology. So, epidemiologists, this is a slide that we use for students, where I use for students, where we talk about kind of a hierarchy of where we can get quite valuable information. And we often say that a cohort study is the best possible study because it's a way of following participants through time. And it's usually set up when participants are disease-free. So they've been exposed to particular exposures or risk factors, and they follow through time to see if they can get diseases or if they get the diseases or not. And there's also a great wealth in studying retrospective cohorts where there are a wealth of data that have been collected. And there's still the advantage that when the initial cohort was assembled, there was possibility for follow-up. And so there's temporality. So you actually know whether the exposure came before the disease. That's not always the case with the cross-sectional study design. Those tend to be very valuable as well in psychiatric epidemiology. For those who've worked with the World Mental Health Survey data, those are repeated cross-sectional studies that are done all over the world and give a sense of exposure and disease, what would co-occur. And then, so as I said, we try to generate hypotheses and establish causality, and we often say that cohort studies are among the most valuable. I did teach this an epidemiology class when I got to Wits with Professor Audrey Pettifor, who's an epidemiologist at the University of North Carolina. She didn't agree. She said that well-designed cross-sectional studies and case control studies also provide a wealth of data and could be superior to a poorly designed cohort study. But these things are sort of works in progress. So I want to now move to a little bit to this sort of idea of public engagement. So note that cohort studies are integrating a follow-up and that there might be burden to participants. So we use the HDSS data to try to assemble cohorts, and then we, in some ways, we really impact on participants. And my colleague Rianne Twine, and I'm very pleased that she actually logged into the talk as well, completed her PhD in 2019 on public engagement, community engagement in the research process in Agincourt. So her work has really examined intersections in public engagement and longitudinal data using the HDSS as a case study, the Agincourt HDSS. And she asks the critical research question of the impact of knowledge dissemination, transfer, and translation of research findings through public engagement in a longitudinal health research study area, so in Agincourt. So overall, her thesis argued for increased public engagement in longitudinal studies, which require participant commitment. So I've said that we follow participants through time in cohorts. So we're requiring commitment because we want them to come back at whatever the time points are that we decide, which could be a year, 6 months, so on. You might not find all your participants. Lost to follow-up is often an issue in cohort studies, but there is this idea that there is going to be participant commitment. And there's always the risk of imbalance of power between researcher and participants, particularly if we work in vulnerable communities, which is often what community engagement is trying to address, as I presented a little bit earlier. And effective dissemination of results really contributes to this idea of social responsibility or public engagement. So Rianne has been very, very productive, and she's produced a lot of papers from her PhD. By the way, you can access the PhD in the Wits library, which is an open library. But I just want to run through some of the ideas behind the papers because they're very specific to Agincourt and to the Agincourt environment. So if you look at this first one, that Rianne led with our colleagues Kathy Khan and Shane Norris, where it looks at really involving stakeholders in determining health priorities of adolescents in the region. So it's qualitative research with stakeholders who are community members to inform the Nchembo intervention, and the aims were to create a continuum of care seeking and self-care behavior from pre-pregnancy through pregnancy, childbirth, and infancy. And the stakeholders really helped to identify priority adolescent health issues that were important to them. Rianne's also looked at effectiveness of knowledge dissemination intervention, again with our colleague Kathy Khan, who is one of the PIs at Agincourt, and aimed to share research findings with villagers, village leaders, and service providers in the study area. And in this paper, there are really important points about the relevance of research and service providers' practices in individual and public health. And then in a third paper, and you can see that from the diversity of journals, so this one is actually published in a sociology journal. So there's obviously interest across disciplines. And this is about the dilemmas of ethics in practice in longitudinal health research, identifying opportunities for the widening participation of residents. So it's really about drawing people to participate in the research process, drawing community members. So the paper 3 recruited individuals and group interviews with resident local leaders and service providers, residents of the study area. The findings suggest residents request their personal screening test results in research studies. So that's interesting. So where participants are actually giving bloods for chronic diseases, diabetes and so on, they're actually requesting their personal screening test results, which seems very reasonable. And the researchers recognize the importance of mechanisms to increase their accountability to residents throughout the research process and the complexity of informed consent and fieldwork procedures. And her fourth paper, the experimental public in longitudinal health research, is really the views of local leaders and service providers in rural South Africa. And this one really touches on mechanisms for increasing user and public involvement throughout the research process, including the generation of research topics. So that's very interesting. So there are ways of encouraging the co-production of knowledge through the recognition of lay as well as professional expertise at different stages of the research process, and their awareness of particular issues of ethics in practice that might arise during longitudinal research. So I'm going to move on to a study that I work on in Agincourt, where there has been opportunity to really drive some mental health research with our colleagues, and also perhaps to present some of the current community engagement, as well as charting the way forward, and perhaps getting some ideas from the audience when we have time for discussion. So the Health and Aging in Africa is a longitudinal study of one of the in-depth communities in South Africa. We call it HALSI. So HALSI follows social, economic, and biological risks for chronic conditions in a random sample of adults in Agincourt, South Africa. And these are adults over 40. And there are 3 time points. The first wave was in 2017, the second in 2019, and there is a third wave planned for this year. There's enough fund. There's been a renewal of funding. And HALSI focuses on cardiovascular disease, on HIV, on cognition and dementia. And it's a collaboration between the Harvard Center for Population and Development Studies and the MRC Wits Rural Public Health and Health Transitions Research Unit, also known as Agincourt. So the cohort, it's a great sample. It's over 5,000 adults, of which 2,345 are men, 2,714 are women over the age of 40, as I've said. It's got a very good response rate in the baseline survey, 86%, which is excellent. The wave 2, as I said, was completed in 2019, and we hope that wave 3 will take place in 2021. In terms of mental health, the Center for Epidemiological Studies Depression Scale, the CESD, was used for depressive symptoms, a short screening scale for post-traumatic stress disorder, and the Gallup World Values Survey questions on subjective well-being and life satisfaction was also used. So for the cognitive functioning, it's harmonized with other health and retirement studies, and there are items on orientation, immediate and delayed recall, and numeracy. And because I've been touching on the area of resilience, in terms of that is potentially asking people about how they actually survive in conditions of adversity, I've added that the interview has a rich set of questions on social networks and social support. So, as I said, we've been working quite a lot, to try to generate mental health questions. And some of these analyses were underway when I came to Wits, and I was lucky to be included and be part of them. So Colin Payne, who was a postdoc at Harvard and is now in Australia, he looked at trauma and found that the traumatic events, which I'm going to show on a later slide, were quite prevalent. There wasn't a relationship with cognition, and I'm going to highlight why that might be. But this paper was published just last year in the Journal of Aging and Health. Then Lindsay Kobayashi, she led this one. She was also a postdoc at Harvard, but now she's at the Michigan School of Public Health. So she looked at particularly childhood adversity and looking at the relationship with domain-specific cognition in the Halsey study. And again, she didn't find any relationship with cognition in this particular study. And I'll highlight, again, as I've said, some of the reasons for that. Then Leslie Adams, another postdoc, led this one, where she looked at, it was really a validity of the CESD by gender, and she found some gender differences. So men were actually more likely to respond better to some of the items on the CESD than women, and that highlights some different research questions. But I was really trying to highlight and showcase some of the mental health work that's ongoing in the Halsey study. So now to move on to some of the work that I'm leading, where I think there are some perhaps intersections with social responsibility and community engagement. So despite these papers by Colin and Lindsay and Leslie Adams, there are still some remaining questions on traumatic events, particularly around PTSD, I think. And because traumatic events are important determinants of physical and mental health later in life, it is quite important that we look at them deeply, because we can try to tap into some of the questions of resilience and social support and public engagement. So we don't, in this study in Halsey, have a measure of resilience. So we didn't use like the Connor-Davidson resilience scale, which is quite widely used. We are using that in some of the adolescent data that I'm also working on. But perhaps future data collection could try to really explore questions of resilience. So the thing is, with traumatic events data, you often don't have a complete data set because not everybody answered the TE data. So actually only about 1,962 participants were found to have complete traumatic events data. Now, this is a secondary data analysis. It's not data that I personally collected, but I'm working on it. And I didn't have a lot of experience with the English longitudinal study life history questionnaire where the TE were taken from. So it was really around getting a head around how these trauma questions were actually asked. And similarly, the PTSD symptoms were measured using the 7-item short screening scale for PTSD battery. So again, it wasn't a scale that I'd had much experience with. So analyses obviously required quite a lot of thought, but it's always about the thought behind the statistics rather than just presenting results. So if you look at some of the TE, they're phrased like this. Now they're all translated into Shangaan, the local language of the region, and back translated. But if you look at them, have you ever had a life-threatening illness or accident? Have you ever been a victim of serious physical attack or assault? Have you ever been a victim of sexual assault? Have you ever been fired or been fired on in combat? Now that might seem like an unusual question, but remember there are a lot of refugees from Mozambique who have perhaps fought in the Civil War. So that question might be relevant. So the way that they're phrased, have you ever, implies that the respondent might have to draw on childhood trauma or childhood adversity, but they're not differentiated in the questionnaire into childhood or adult traumas. And there's also, questions around parental psychopathology, which also is asked in the World Mental Health Survey, for example, physically abused by parents, another childhood one. And then natural disaster, also probably quite relevant to Mozambican refugees, floods or something like that. Have you ever witnessed injury or death in combat? Again, relevant to some of the participants from Mozambique. Have you lost a close friend or relative in the military, or a close friend or relative has died or had a serious accident or illness? Okay. Then the PTSD screener, people who work in trauma epidemiology might recognize Naomi Breslau, who is quite a well-known psychiatric epidemiologist. She died quite recently, so there was quite a lot of attention, obituaries in the New York Times and so on. So this short screener for PTSD seems to have been quite well validated in an old paper in the American Journal of Psychiatry in 1999. And Ron Kessler, who's well known to some of us, the PI of the World Mental Health Survey at Harvard, he was involved in this validation. So this is the one that was used, and it really has the PTSD symptoms. Commonly in the literature, a number of the symptoms would be from the DSM. If participants reach a threshold of the symptoms at a cutoff, then they would be likely to have some kind of PTSD symptomatology. That's how it was commonly used. But what I did is, because I work with statistician Jonathan Levine, who's actually my boss as well, and he's been working on advising me with some of these analyses. He prefers to keep it continuous. He doesn't like to reach a threshold. He doesn't like to use a cutoff, because he feels that then you're actually missing out on some people who might have had a trauma if you do a cutoff. So what we've done is we've tried to look at an adjusted mean PTSD score presented by the absence or presence of each traumatic event. So each of those traumatic events that I showed you. But what's interesting, so this is a way of really deeply looking at some of the PTSD data. So just to present, this is just what the sample looks like. You've got 41% male and 59% female. The mean years of education is very, very low. It's about 6 years. So people are, looking at an average of only reaching primary school, and actually a minority are Mozambican and the majority of South Africans. And the most frequently reported TE seem to be losing a close friend or relative who's either died or had a serious accident or illness. So it's not really differentiated between death or serious accident or illness. The second most highly reported is ever had a life-threatening illness or accident. And the third, I just took 3 of them, is witnessing injury or death in non-combat. Okay, so that's about 51% who say they've witnessed that. At this point in this analysis, none of these traumas, the PTSD score doesn't seem to be higher in relation to trauma. So there's not actually a significant result. So in some ways, it corroborates what our colleagues did in terms of trauma data. And there could be a number of different reasons. There could be underreporting of traumas. There could be ways that the questions haven't been well understood. This trauma epidemiology is complex, and we often don't see significance. There are some proxies for resilience in the data set, example, belonging to a support group. And if that is a way to sort of measure, some sort of engagement, just to ask people how they actually survive in context of great adversity, then that deserves some sort of further engagement. But as I said, there isn't a resilience measure. There are just a few questions that maybe relate to social support or perhaps some kind of network. So if I can move to healthy and social responsibility. So we acknowledge that a cohort study consisting of 3 waves could probably burden participants. There has been feedback of results to healthy participants. So whereby a field worker phoned all the participants in a particular village to invite them to the feedback, also drove around the village announcing the meeting over a loud hailer the night before, and 50% of healthy participants actually attended the feedback discussions. So there has been an effort around public engagement, around social responsibility. So really, my conclusions are really around public engagement is an emergent concept in research. And there's evidence of public or community engagement in mental health or public health research, but perhaps that's the way forward in Agincourt, to try to devise some sort of program for real community engagement in relation to mental health, because there are infinite opportunities for research on traumatic events and specific public and community engagement. It's a very exciting place to be. And there's potential to also examine resilience. So how would we actually try to integrate the two? Like, how would we really integrate resilience and community engagement? Because it is a very critical question that some people really seem to survive in the face of adversity. And perhaps resilience or resilience measure can be considered as a form of empowerment for communities. And these are some of my acknowledgements, my Wits colleagues, Kathy Kahn and Steve Tolman, who are the PIs at Agincourt, who include me in studies, and there are always infinite opportunities. Rianne, who, as you know, she was quite surprised that she's oversighted in this talk. Ryan Wagner and Xavier Gomez, Lindsay Kobayashi, who helped quite a lot, has been helping me quite a lot with analyses. Jonathan Levine, who I mentioned, biostatistician, who, as a boss, allows me a lot of space to work with Agincourt. And if I don't send in the grades for the Introduction to Epidemiology course on time, he often accepts that it's because I'm writing a paper with Agincourt. And Dan Stein, who has allowed me to continue to bounce trauma ideas off him since I've left 4.5 years ago. So thank you very much for the opportunity to share some of the ideas. And just to acknowledge some of the funding, I have an MRC SIR fellowship and a Claude Leon Early Career Research Award, and the Halsey study itself, it's an NIH grant on aging from the NIH, and it's nested within the Agincourt unit, which is also supported by Wellcome Trust grants. Thank you very much. And if there are any questions.
Thank you, Sumaya, for an excellent lecture. Nasira, would you share the discussion?
Dan, I think you can. I think you're far more versed in this area.
Okay. Thanks, Nasir, for arranging, and to your committee for arranging a wonderful start to the year. And thanks, Sumaya, for an excellent talk, and for being generous about so many people you've worked with. I am happy to take questions from anyone. Petra says, thank you. Someone asked where the registrars, and I know that we have some ill right now and others on exam leave. I hope they'll join us, more of them will join us over time, and we'll ask Sumaya to set them a question on trauma and epidemiology, or one on community engagement. Please, Simone, please, Simone, please go ahead.
Hi, Sumaya. Thanks for a great chat. I did have to pop out at one point, I must admit, during the conversation. So please excuse me if you did cover this. I'm curious to know whether for invalidating these various questionnaires in Agincourt, were there any non-psychometric validation work has been done in the kind of in the frame of community participation? And particularly, I'm interested in the work around cognitive interviewing or cognitive testing. I've had some experience recently with this method and have been blown away at the degree to which cognitive interviewing and testing really throws up quite significant flaws in some of the tools that we use from a kind of a cultural and cognitive coherence point of view. So very often questionnaires that may well perform beautifully from a psychometric point of view perform poorly when you ask participants how they understand constructs, time periods, Likert scales often fail when you actually test with the users, with community themselves, their understanding of these kind of cognitive paradigms.
Thanks, Simone. As far as I know, the cognitive screeners were validated. They were all, I think the validations were actually complete by the time I came here and came onto the study. But I'm going to send some of my adjunct court colleagues have actually logged into the talk. I'm wondering if Kathy, I think you're there, wouldn't like to also respond, Professor Kathy Khan, because she could give a bit more background if she is still there.
Hi everybody, and thanks Sumaya for your great talk and acknowledgement of the people that you've worked with in Asian Court and the different partners. And thanks for your question, Simon. Yes, there's been a lot of work on the different scales and tools that have been used. The Halsey study, as it's called, our aging study, is funded by the National Institute on Aging, part of the NIH, and is one of the sister studies in the HRS suite of studies, the Health and Retirement Survey. And there's a lot of work on harmonizing the different tools and instruments that are used there, and so quite extensive work has gone on looking at the tools that we have used. But I think it's a really important question, how these different tools that are harmonized and used in a number of different settings globally in the global South, as well as northern countries, the US, UK, Ireland, Europe, how they do perform in the comparative work that is done and is envisaged in these different contexts. So I think it's a very important question that you raise. We also, not necessarily identical scales and tools, but we do a lot of work also in adolescent and young adult age groups. And so looking at how these instruments work in different age groups, who in the certainly in rural context of different, very different educational levels and exposures and so on, I think is also important.
I guess my question was less about kind of validation in a conventional sense in terms of the psychometric properties, and more in the sense of cognitive coherence and cultural coherence. And just share an example, when we did some cognitive testing work with a kind of very simple mental health tool that we developed, which incorporated an element of questioning around anhedonia and lack of interest or pleasure in things. We discovered that even though that item in the psychometric work had performed beautifully against a diagnostic gold standard in a ROC analysis, when we actually asked women from three different language groups what they understood by a lack of pleasure or interest in things, their cognitions were completely different from the intended the intended construct of lack of interest. So in fact, we were asking, this item in the tool was asking about something that the community were interpreting completely differently from us as administrators of the tool. So it's a very particular technique that really works quite deeply with community understandings and concepts around constructs that we as scientists assume quite often are well understood, but when you ask about them, you realize that there's a disjunct quite often. So I'm just wondering whether that work has been done, and Agincourt strikes me as a fertile ground for learning wonderful things in this regard.
Great, thanks, Simon. I don't know if Sumaya or Kathy want to respond.
Kathy, do you want to respond?
I'm not sure that this addresses exactly what you asking, Simon. I think it's a really important question, and Rian, you should come in. Some of our early work, I mean, it's not the tools, and it doesn't deal with psychometric testing, but some work we did a couple of years ago with a colleague at Oxford University, who sadly died very prematurely, Glyn Humphreys, who was developing tools that tried to move away from the need for those kinds of, how can I put it? To move away from the need for that kind of cognitive, that kind of understanding. So move away from the need for kind of numerate or numeracy and literacy to be more applicable in settings like, you know, rural parts of Africa or Asia. So I don't think it entirely addresses what you're looking for, but I think that you know, it's highly relevant.
So I agree. It's a very complex discussion, and you know, for example, do we alter the tools based on a cognitive interview to suit the local population, or do we keep the tools roughly the same in order to enhance cross-study comparison? There are a couple of people in the audience who I'd love to hear more on this score, but I think I'm just worried we should probably get to other areas we haven't covered. For example, Margie's question about COVID and wondering whether Halsey and the site in general, Agincourt in general, has considered looking at the impact of COVID. Sumaya?
So there has been quite a large response to COVID in Agincourt. I haven't been involved with it. Kathy, I'm sorry to put you on the spot again. Perhaps you just want to expand a little bit on some of the COVID-related activities.
Sure. Thanks, Margie, for the question. So so just in terms of Halsey directly, yes, we in revising the tool for wave 3, which we hope to go into the field within the next couple of months, there will be questions to look at COVID, and that will be integrated into the tool. But more broadly in Agincourt, we have got COVID surveillance underway, introduced as of April last year as part of the health and socio-demographic surveillance. So that goes to all households in the study area. So all members of the Halsey cohort are therefore part of those households. So already there is information on Halsey participants. We also have other work. You know, we were fortunate in having a small call center, which we expanded. so have been able, right from the onset of lockdown level 5, were able to conduct telephonic surveys. But we also have a cohort looking at the socioeconomic and behavioral impact of the COVID-19, as well as the various lockdown measures and restrictions on this rural population. And we have a SARS-CoV-2 prevalence and transmission survey, an intense study in collaboration with NICD. So there are various studies and intersecting, and some of which are in this Halsey population. So with the detailed data that we have on this older population in the Halsey cohort, there is quite a lot on COVID that we will be able to bring into the analyses.
Great, thanks. I guess I have a question for Sumaya, and I'm noting that I wouldn't ask a question, but there aren't any others in the chat right now. Sumaya, it strikes me that the community engagement that you are advocating for is not dissimilar from the advocacy for participation of mental health users, or whatever other word you care to use, in mental health research, asking people with lived experience of mental disorders what they want researched and how the research should be done. I mean, do you think there's some overlap between what you're talking about and that body of literature?
I do think that there is some overlap, Dan, between these sort of models of community engagement. I mean, what exactly are you referring to in terms of mental health? Were you thinking about a model like Friends for Falkenberg, something along those lines?
I think more and more people are calling for, at protocol development stage, input from people with lived experience.
Yeah, that is definitely something we envisage. When I try to introduce the concept of resilience, I'm also thinking along the lines of really interacting with users and also asking questions about resilience. Crick touched on that in some very early work. I think actually he might have published that with Leslie Swartz on traditional healers and people with mental illness, was published in the 90s. And I think, Dan, we also worked on it a little in relation to the SIP study, where we actually really asked mental health users what their priorities were, what their expectations of treatment were. So yes, I would envisage something similar.
Great. Well, we've reached the hour. So thanks again to Nasira and her committee, and a particular thanks to Kathy and others for joining us and speaking. And huge thanks to Sumaya for educating us about this really important topic, and for doing all the work that she is doing. So thanks to everyone, and see you next week.
Thank you.
Thanks, Sumaya. And
thanks, Kathy. Speak soon. Bye.
Everyone. Bye-bye.